Welcome to Clinical Minute. Julia is a 20-year-old woman, gravida 0, para 0, who presents to College Health Services for a contraceptive consult. She became sexually active at 17 years old and has been in a monogamous relationship for the past 6 months. She and her boyfriend use condoms consistently. She would like to switch to a contraceptive method that is more effective. She does not want to use combined oral contraceptives because her older sister had difficulty remembering to take them and became pregnant at age 16. You review Julia's available health record and confirm the following. She began menstruating at age 11 and has regular menses with a 28-day cycle. She has light flow and has never had spotting between periods or cramping. Her last menstrual period began 5 days ago. She has no significant health history, is taking no medications, and has no known allergies. Julia reports no tobacco or recreational drug use. She drinks alcohol socially and denies binge drinking. On examination, her blood pressure is 110/70. How would you approach the contraceptive consult with Julia? It is helpful to consider a shared decision-making framework with any patient encounter. The steps of shared decision-making include 1. Query to identify preferences using open-ended questions. 2. Provide information about side effects, effectiveness, and use of method, including written materials in the appropriate language and literacy level. 3. Give context about options, allowing patients to hold devices if possible. 4. Ensure access to method placement and removal. 5. Allow time for and encourage questions. When working with a woman in a contraceptive consult, it may be helpful to consider this checklist of topics to cover: effectiveness, mechanism of action, characteristics of the method, including any changes in menstrual flow, side effects and possible complications, STI prevention, insertion and removal procedures if relevant, instructions on follow-up. You begin by asking Julia about her future plans. One key question is an initiative launched by the Oregon Foundation for Reproductive Health. The initiative encourages primary care providers to routinely ask women of reproductive age a simple question: would you like to become pregnant in the next year? You ask Julia the one key question. She responds, "No way. Someday I want to have children, but not anytime soon. I want something that really works but is easy to use." You use open-ended questions to better understand what concerns Julia has and what she already knows about her contraceptive options. She shares that her older sister became pregnant at 16 because she forgot to take her birth control pills. She states she doesn't want to use the pill because she is afraid she will also forget to take them. You show Julia a chart that illustrates the different tiers of effectiveness of contraceptive methods. You show her that her current method, condoms, is in the lowest effectiveness tier, meaning on average, 18 or more women out of 100 will become pregnant each year when using this method. You consider Julia's history and preferences. For which of the highest tier methods would Julia be an appropriate candidate? She is not a candidate for the permanent contraceptive methods because of her desire for children in the future. Is she a candidate for an IUD or an implant, which are sometimes referred to as LARC, or long-acting reversible contraception? Long-acting reversible contraception includes the contraceptive implant and intrauterine contraception, or IUC. Most women are candidates for LARC, including adolescents, young women, and nulliparous women. In fact, the American Association of Pediatrics has stated that LARC methods should be considered first-line contraceptive choices for adolescents. Women with a history of ectopic pregnancy can also use LARC. IUC can be inserted immediately postpartum or post-abortion. The copper T IUD is a highly effective form of emergency contraception. You consider the contraindications for the contraceptive implant and IUC. This slide shows the contraindications for use of the contraceptive implant. The listed conditions are Category 3 and 4 contraindications designated by the World Health Organization. For more information, see the WHO Medical Eligibility Criteria for Contraceptive Use. Note that implants are contraindicated when a woman already using the method has developed ischemic heart disease, stroke, or migraine with ARA, but are not contraindicated when initiating the method in a woman who already has one of these conditions. This slide shows the Category 3 and 4 contraindications designated by the WHO for use of IUC. Note that initiation of IUC is contraindicated in a woman who has active endometrial or cervical cancer, but not contraindicated in a woman who is already using IUC and develops one of these conditions. After considering Julia's history and preferences and possible contraindications, you determine Julia is a good candidate for either the contraceptive implant or IUC. You show Julia an implant and an IUD and discuss the two methods in more detail. You let Julia know the contraceptive implant contains etonogestrel, is placed in the upper arm with a local anesthetic, provides 3 years of continuous pregnancy prevention, provides rapid return of fertility after removal, is not large in size and does not travel to other parts of the body, does not require surgery for insertion and removal, must be removed within 3 years. A new rod can be inserted at the time of removal. Is not visible once placed, but may be palpable, and requires non-hormonal backup contraception for the first 7 days after insertion. You also describe IUC in detail. You inform Julia that IUC includes hormonal IUDs and the copper-containing IUD, has the highest patient satisfaction among methods, provides rapid return of fertility after removal, is immediately effective, provides long-term protection, 3 to 10 years depending on the IUD, and may require backup contraception for the first 7 days after insertion. The copper T IUD never requires backup contraception. The hormonal IUD does not require backup contraception if inserted immediately after a first trimester abortion or during the first 7 days of the menstrual cycle. And you reassure Julia that implants and IUDs are not abortifacients. The implant prevents ovulation, and IUC prevents fertilization. Do not cause ectopic pregnancies or pelvic infection, and do not decrease the likelihood of future pregnancies. You describe to Julia the possible menstrual changes associated with LARC methods and how these would be managed. Implants are associated with infrequent bleeding, amenorrhea, and prolonged bleeding. In many women, these changes improve over time. Most women using the copper T IUD experience an increase in the duration and amount of menstrual bleeding, which often lessens by the first year of use. For women using hormonal IUDs, the bleeding pattern is unpredictable. Many women have spotting and irregular bleeding during the first 3 to 6 months. Most women have reduced bleeding or amenorrhea by 12 months after insertion. Some options for managing these side effects include counseling up front and reassurance, naproxen, ibuprofen, or estradiol in the dosages listed, or combined oral contraceptives for 2 or 3 cycles. You also mention the most common side effects other than menstrual changes that may occur with LARC and the possible risks. For both the hormonal IUD and the implant, side effects related to hormones may occur, such as headaches, nausea, depression, and breast tenderness. Possible risks of use of the implant include problems related to the insertion or removal. These occur in less than 2% of women. Possible risks of the use of the IUD are more likely just after insertion and include expulsion, which occurs in about 5% of IUD users, and perforation of the uterus, which occurs in about 1 in every 1,000 insertions. The risk of pelvic inflammatory disease, PID, is slightly higher in the first 3 weeks after insertion, although the risk remains low, at less than 1%. In the rare case that a woman becomes pregnant with the implant or an IUD in place, she is at slightly higher risk for an ectopic pregnancy. You ask Julia, "What questions do you have for me?" She responds, "Do my boyfriend and I need to keep using condoms?" You tell her that neither the implant nor IUC will protect against sexually transmitted infections. To ensure Julia understands the key points from the consult, you use the teach-back method. For example, you say, "Tell me what you will use if you experience cramps." Julia is able to answer your questions correctly. Julia tells you she would like to use the copper T IUD. She asks for a next-day appointment so that she can bring a friend with her. You describe the insertion procedure and suggest that Julia take some ibuprofen just prior to the insertion to help with the pain typically experienced during insertion. You instruct her about the signs of complications, such as expulsion and infection, and tell her about the importance of the follow-up visit after the IUD is inserted. Julia thanks you and heads to the front office to schedule the appointment.